We are on?
Yes, Dr. Kwon,
Yeah.
you are live at the coronary theater. Are you
Yeah.
ready to introduce your team and present the case?
Yeah, I'm just doing the IVUS pullback speed. So, okay, let it pull back. Okay, my name is Hyeon-Cheol Gwon. Welcome to Samsung Medical Center, and I'm working with Dr. Jonathan Hill from King's College Hospital, and he's an expert in the CTO. He's running the CTO proctor group in London and the proctoring Europe, even China, and everywhere in the world. And say something.
Yeah, so well, it's a pleasure to be here. We've started the case already, so we've made some fairly rapid progress with a case not quite as challenging as we thought initially, but I think there's some very interesting points that we can discuss. We're getting some imaging now.
Okay. So the third operator is Dr. Woo-Jin Jang from Samsung Changwon Hospital, and we have no IVUS specialist because I'm special. Okay, Dr. Jang, please present today's case.
Next slide. Yeah,
Slide.
I'm Dr. Jang from Samsung Changwon Hospital, South Korea. Let me introduce our case. This patient is a 68-year-old male, present with exertional chest pain for 3 months. 19 years ago, he had been treated with PCI for proximal LAD using BMS for stable angina. His recent echocardiography shows normal LV systolic function and no regional abnormal wall motion abnormality. His risk factors are hypertension, diabetes, and hyperlipidemia and prior PCI. Next slide. This is the baseline ECG. There are no significant abnormal findings in this exam. Next slide.
So basically, this is have a chest pain for 3 months, and the stent was implanted 19 years ago, and the 3 months. So it's recently developed pain, or the more than that, we don't know by the history. So this is angiography we have done several weeks ago. RC was normal. There is some disease in the PDA. It's not so complex lesion. We can see the collateral flow from the PDA to LAD. Next slide. So culprit is LAD total occlusion, ISL CTO. Actually, you can see, next slide. You can see some stump in the epicaudal and iliacaudal view. But circumflex ostium, there is no significant disease. So can you put on today's angiography? I'm sorry. Slide again, please. Sorry. Next slide. So our plan is PCI for CTO ISL lesion, and the provisional approach. Issue here is do we need Lima to LAD versus PCI, and successful wiring for austere ISL CTO. And thirdly, risk of circumflex occlusion during a provisional approach. So circumflex ostium is disease-free, almost disease-free, but the angle is acute angle, and also there is a lot of plaque burden, and especially due to the ISL. And also I'd like to discuss the proximal optimization, or possibly part side part repart technique versus final casing ballooning. Next. I will review one or two slides. Next.
Just round my nose.
Slide.
Next.
Thank you.
Okay, the CTO, actually, the success rate should be higher than the novo CTO ISL, but the published paper says its success rate is 60 to 87%. More importantly, target vessel revascularization rate is higher in the instant CTO compared to novo CTO. That's why we are considering the bypass surgery in some patients. Next slide. So we'll talk about the proximal optimization in our COVID-2 registry. If you, especially if you apply the final kissing ballooning, the path is very important because there will be a significant size difference between the left main to a LAD. The path or not, it have a higher influence to TLR rate for 3 years. So far, yeah, this is our presentation. So
Okay.
Dr. Hill, any
Yeah,
comments?
so seeing this case, really, I think that presents a number of challenges.
Angel screen.
The entry
Angel
into the
screen.
CTO here, I think, was unambiguous. So I think we weren't facing the challenges of
Angel
having
main
a
screen.
left main LAD flush occlusion, which really is, I think, one of the most challenging situations. You've got an unambiguous cap and entry into the CTO segment. So it's relatively short segment, and yes, there's good retrograde filling, but this is a primary antegrade wire escalation case. Now, in particular, with these segments of in-stent occlusion, one of the techniques we've been applying with the ADR system is actually using the cross-boss catheter. And so we've been going with a primary ADR approach, so using cross-boss. And unlike a non-stented vessel, you don't have the challenge with going into subintimal space and generating a large hematoma. It's contained within the stented segment. So you can use the blunt dissection technique, and we've had very high success rates with using cross-boss in this particular context. I think we've got some slides.
Slide,
Could you go
please.
to the next slide? So looking at cross-boss in
Slide on the
particular
main
for
screen.
in-stent restenosis. Just go to the next slide, please. So
Not yet. Okay.
this is the algorithm we've been applying for ISR. So if you see on the left there, our first strategy has been to go primarily with cross-boss and wire escalation then if the cross-boss stalls. Our second strategy would be just going to conventional wire escalation, and then our third strategy would be to retrograde. And obviously there are retrograde options here, and there are antegrade options here. So slightly unusual approach with a cross-boss first. And just go to the next slide, please.
Next.
So, and click through, please.
Click.
Through. Just click, 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 click. So just go to the next one. This is just a little background about the approach with ISR and really why cross-boss, I think, works in this situation. Go to the next slide. So this is the mode of failure, really, so you can't cross with the wire, you can't stay within the struts. And the other predictors of failure is that the longer the vessel has been occluded, the more likely you are to fail. The smaller the initial stent diameter, if there's a large side branch at the proximal cap. And in fact, we haven't really studied these patients particularly well, so CT ISR is usually excluded from the CTO trials. Go to the next one, please. Next slide. And so in the FAST CTO study, which has been reported earlier in this meeting, these patients have not been studied. So we had a look at systematically at a group of these patients with our early experience. Go to the next one, please. Next slide. So we had a 80% success rate with 25 patients. Our crossing time was an average of 15 minutes. And these were successful crossing going from lumen to lumen or true to true. And so the cross-boss will find its way to the distal lumen. You can redirect the catheter with a guide wire if you have to. Now, all of the cases that we tried in this initial series had previously failed antegrade. All were ultimately successful retrograde. But all of the contributing factors I've discussed were featured in that failure. There have been no complications with this approach, so it's a relatively safe approach. Now, cross-boss isn't available currently, so we're not going to be using that today, but that's one of the approaches I think we should be thinking about in the future to simplify this type of case. Perhaps we should move on to show you what we've actually done.
So please, the angiogram on the main screen. So I tried to prepare the kind of complex CTO for you. Actually, this angio, after 3 weeks after the previous angio, actually we find some antegrade flow. I'm sorry for that.
It's okay.
So this is first angio. We have prepared the bilateral angiography, diagnostic angio from RCA. Next slide. Okay, you can see that. Next slide. So at 3 months occlusion is some antegrade flow. Next, without the retreat. Next slide. Next. Yeah, this is angiogram without the bilateral injection. So it got easier, and the issue is that how to treat left main bifurcation with a lot of plaque burden. It changed.
Yeah. You can see really it's a very bulky plaque. We can see the outline clearly in this projection here. So there is a reasonable length of LAD which hasn't been stented, but really there's quite extensive plaque extending back to the mid segment of the left main. So we've really now got faced with the challenge of how do we manage this left main and this bifurcation, assuming that the wire goes down.
Now we are ready to hear advice from the panels, and especially from Dr. Park, specialist, the left main. But so what do you think is the mechanism of occlusion in this patient? So just 19 years after the first perimeter stent, it was micro GFX. So, or the mechanism can change the treatment plan?
Well, from the views that we can see here, I mean, the occlusion point was actually proximal to the stent. I think there was really heavy plaque burden, and we can see that now in this segment proximal to the stent. So I think this, whether or not this was generated by an edge effect with the original stent, but certainly I think there's been progression of the proximal plaque. It may not necessarily be, a primary stent failure.
So some recanalization after 2 or 3 weeks means that there is some thrombus or plaque rupture mechanisms working here. So we need to concerned about some dystembolization or something, just like organized thrombus is make work. So we need to concern about that. And actually, yeah, next. It looks too easy for you, okay? So I used the backup catheter is just 1.5 balloon. So I like to use a ENCORE SEOUL if this is very complex CTO, but this is should be simple. So I started with the top 1.5 of the wire balloon. This is the ultimate wire, 3 gram. It's my favorite for CTO. The soft enough and the stiff enough.
Stiff enough.
And soft enough, stiff enough, and really good feedback, tactile feedback. So next. Of course, there are many occasions that the wire is going outside. It's going in one view, in another view is going outside. But next. So I straighten it by the angiography. And this is angiography from RCA, the wires in the diagonal. Next. So wires in LED. I change to next. I make a hole with 1.5 balloon and get the angiogram to get a more clear view of the stent. You can see the target lesion is very short, but still distal half of stent is there is a lot of plaque. Stent resistance is up to maybe it was present 3 months earlier than this procedure. So next. And we did a 1.5 balloon, 14 atmosphere. Next. And changing next to a soft wire. And we did the IVUS. But I like to, this is where we are now. But Dr. Hill insists that we need a OCT to understand more about. this is a simple, it became a simple case, so I like to show a lot of image to enjoy, for you to enjoy. So, firstly, okay,
This is
get the
going in
OCT.
LED, is it?
Yeah.
Yes, we may not see clearance distally. We
So
may-
actually, I prefer IVUS for the left main bifurcation
Sure.
because it tells more information about the vessel size, which I believe is the most important information. But
Yeah.
you
I've
prefer
become-
OCT.
I've
Why is
become
that?
Completely convinced that OCT is a superior modality in the left main, especially for bifurcation sizing. So the key parameters that you want are the size of the two limbs, so the size of the two limbs,
Ready?
and then the
Okay.
size of the left main.
Sure.
And I think the concerns that we've had
Sure.
of not being able to opacify the left main properly, I think we've largely put those to rest. I hope that we get some good pictures from this. And certainly the two main measurements are the limb measurements and the parent vessel, so the left main size.
And also, you want an OCT
Yeah,
from
well,
the
let's-
obtuse marginal?
Yeah, just so we can
Okay,
see the
yeah.
bifurcation anatomy, because
Okay.
this is a bifurcation case now.
Actually, to be
Just
frank,
flash.
I fully understand, fully agree with you, but I follow your plan.
So we haven't looked at those pictures. So the clearance was reasonable, but we'll get some more information about the left main from this.
Yeah.
So the injection, what injection volume is
are-
going in here?
Injection here. Okay. So I didn't see the images. The images are not so clear.
No.
Distal to the lesion.
No, so let's just do the circumflex and we'll get the left main size there.
Okay. Still, what we did just 1.5 balloon, and if we want, we
Yeah.
dilate with 3.0 balloon or
Sure.
more
Let-
to show you
we
the
can see on the
mechanism.
circ, you may need to put your wire down a bit further.
Epicotal. Still obscuring the mechanism. So larger balloon, it's difficult to know the mechanism actually.
Just
So
make sure,
okay, here.
just make sure your guide is properly and you're out. You need your wire out.
Yeah.
Just your wires come out a bit of the marginal.
Okay. So
And
anyway,
just check with a little
Just check.
test that the
Test.
guide is in properly.
test.
테스트.
Okay.
Okay, so you should
Okay.
get good opacification there.
준비. Ready?
Ready?
Okay.
Good injection, please.
Shoot.
Go. There we
Okay.
are. All right.
These days we use a dextran rather than contrast media to reduce the dose of contrast medium.
Okay.
But I
look.
think image is clearer with the contrast dye. Any questions or
Circumflex.
comments?
Shall I show you the circumflex pictures? Okay. So this shows actually relatively poor clearance, but I'll see what information we can derive from this.
Sorry. OCT on the screen, please.
Can you see the OCT projected there?
Yeah.
Yeah.
Sure.
Okay, well, we're in the distal lumen here. You can see, and now we're getting into the stent. So I'll give you some information about that stent size. So that's 3. But if you're looking at the vessel size, it's clearly significantly, it's over 3.5, that vessel. We'll get some more information more
Slide.
proximally. So this is not good clearance within the segment, so in terms of the diagnostic information, limited. So I've got a little bit of information there, but that's because we haven't done any ballooning within the LAD segment, only with a 1.5. So this is going to the circumflex. So what this is going to do is give us the size of the circumflex lumen, and I'll put on the lumen profile. So here's the lumen profile. And here we go. We can see very clearly nice images within the circ. I can see the external elastic lamina here, so I know this vessel size. This is a 3.6 vessel. Okay. Coming in, let's see, let's just rotate round so we can see, we should be able to see the wire going into the, and here I've got the vessel size. For me, this is good information. so it's slightly
This
eccentric.
is left main.
So this is a 5.7 EEL measurement here. So certainly the optimization within that segment would need to take place with a large caliber balloon. So at least a 5. There is a degree of eccentricity, and we've got fallout here from the wire, but certainly I've got some useful information. Let's going a bit more proximal, a bit more distal. So that's 5. And then a luminal size, if I'm wanting to get apposition in this plane, that's 4.
Okay.
Going in the other direction, let's have a look from the other side, 3.5, 3.6. So to get apposition within the more distal segment of the left main, here we've got some more information here. Apposition, so at least a 4 in the distal segment of the left main to get apposition. So your pot is going to be 4 in the distal bits, and if you need to do it more proximally, depending on where you position your stent, this is quite soft, nasty soft plaque here, then you're going to be up to over a 5.
So initial stent size was also 3.5.
Well, so the stent
maybe
size
we can
would-
start with the 3.5 if
Yeah.
we implant a stent.
Sure.
3.5 stent and the 4.5
Sure.
post-dilatation
Yeah.
will optimize. We achieve optimal proximal expansion, I think. So to compare with the OCT, actually I prefer IVUS. Just
Okay,
I said.
so why don't we
I can
have a
show
look?
you the IVUS again.
Yeah.
IVUS 2. IVUS on the screen. Please don't misunderstand me. I use only IVUS during the procedure. I don't use both. Okay? Distally. As I'm more focused on the vessel size, and the lumen size is 2.5, 2.75. The vessel size is more than 3.5,
Here we
almost
are.
4.
So we
So,
can do a good EEL measurement here.
Yeah. So stent, no, not yet. This is calcification, distal to the stent. Okay, this is the stent coming. So plaque is diffusely covering over the stent. So we need some consideration of this distribution. And there is a huge amount of plaque, even in the 2 millimeter lumen in distal of the stent. It's, yeah. Okay, this is the culprit lesion, total occlusion. So the IVUS vessel size is about 5. Stent size is about 3. We need a further expansion if you like to optimize the stent, but 3.5 is good enough.
Possibly.
5.0 is too big.
Yeah.
Okay, this is the left main ostium coming the circumflex from the 7 o'clock.
Yeah.
And left main is also diseased.
Yeah.
And vessel size 5.5, lumen size 4.0, very similar to IVUS. There is some discrepancy though, so IVUS measures a little bit larger.
But these
than the
pictures
OCT,
are
but,
good. They're just not as
practically
clear
it's the
as
same.
the OCT, so, but useful as well.
Okay,
Okay.
a lot of image and a simple procedure maybe. So any comments, and please comment on the neointimal type in OCT image. I can show you and you can comment that.
Yeah. I mean, I think to
OCT
obtain
image
proper
screen.
imaging OCT-wise, we would need to do some more pre-dilatation, and then we would get better clearance.
total
I think you would then
occlusion
be able to
위치에다가
characterize it much more clearly. Certainly we can make some informed decisions from the IVUS, but I absolutely agree you're going to get that more of that sort of detailed information from the OCT.
Actually, Dr. Kim, Byung-Gu Kim has some data, and we have also published some characteristics of ISL, the peristent low, what do you call it? So the evidence of some neoatherosclerosis, but I found it's very difficult to characterize the total occlusion, not distal, approximately. Where is the total occlusion? Oh,
Yes, it hasn't been cleared properly.
Yeah.
So that's the problem because we haven't got distal clearance.
so 6 to yeah, all around. Here you'll find a lot of lipid content all
Right,
around
right.
the plaque. Is that right? Yeah.
Okay.
Okay,
Shall
so
we do some
that
bleeding?
will change your strategy to treat patient. 3.5, 20.
Yeah.
So OCT findings can change your plan to treat.
Certainly, we use a co-registration system, so the Optis-I co-registration system, and we find that a really nice way to plan cases. So all the stent sizing we make from a single OCT run. It's actually reducing the amount of contrast we're using for the cases.
2.5,
Yeah.
3.5, 3.5,
2.5 or 3.5?
3.5.
3.5 for the proximal bit, but you need to balloon the distal lesion.
You want to start with the 3.5, 2.5?
Okay, well, I think distally, you know, the segment we saw on
I
IVUS.
start inside the stent,
Okay, well,
and
let's-
the way
yeah.
we can add some
Yeah.
ballooning. So yeah,
So 2.5 or 3.5?
3.5.
3.5.
Dr. Gwon,
yeah.
you won't believe me, but you're in a live case and we have some time. So will you tell us what is your plan?
Yeah.
Because we
Okay,
don't know
that's-
your plan yet.
Yeah. So I dilated with the 3.5 as
We're just about to dilate with the 3.5.
maybe a DB is another option, but this is diffuse disease.
Sure.
The plaque is going over the
I
stent,
don't,
and also the distal left main is diseased.
no, this is not
So
suitable
if
for
there
DB.
is yeah, right.
It's
If I
this-
dilate with only balloon, there is some geographic miss in the distal left main. So my plan is to implant a stent.
Yeah.
So, but the sizing is tricky because the distal lumen is just 2. Maybe we gave the nitroglycerin, but it's not fully dilated. But so I'll check again with I dilate the stent inside the stent with a large balloon. Then we'll check what will happen.
This is a 3.5 balloon we've got at the
3.5 is
moment.
slipping, this ISL deflation.
Watch the guide there. Yeah. I'll have to
Okay, I
move the segment
dilate
back
here. Yeah,
into the left
inflation.
main, yeah.
The NC balloon, actually, we need a larger balloon. The vessel size is 5. The 3.5, actually, stent size is 3.0. So it doesn't matter, it's non-compliant or compliant, 3.5. I think. So for full dilatation, actually, if you need it, NC balloon or post dilatation, opposed to please remember that the proximal LAD is a 5, vessel size is 5.0. Okay? I'm carried away. Yeah, Andrew?
네.
Sure. Okay.
I think we should do
and
another
epicaudal?
full OCT run here, and I'll show.
Another OCT.
so one
Okay.
more OCT, maybe.
Usually I don't do that, and but it's lab demonstration, and
We will show
Yeah,
show
yeah.
how useful
Andrew?
it will be in this situation. Great.
really.
Yeah, it will be great.
Okay.
So could we go
Yeah,
back to the
OCT.
PA cranial view, please?
At cranial. Yeah, I will show the OCT just for the learning issue, actually.
Okay.
So amazingly, you can see that there is a lot of plaque burden, but it doesn't seem to migrate into circumflex. That Andrew? Because in our IVUS study published in JAG several years ago showed that the plaque is coming from the proximal. I mean, coronal shift is coming from the distally. And the
No,
angle
that's
and the vessel
sorry.
size is important.
No,
The
so
plaque
that's
is...
IVUS.
Oh,
Yeah,
sorry.
sorry.
Okay.
You only knew that by
Yeah.
mistake.
Okay, yeah. I'll explain what has been going in this cath lab. So, angiogram, this is just the point that you left. We are dilated with a 3.5 balloon. Next. Yeah, OCT was done. And what was finding at the time?
So the finding
OCT?
with the LAD OCT, so substantially bigger vessel than had been
Yeah.
thought of at the initial stenting, so 3.5 to 4
Yeah.
millimeter vessel proximally, and distally, so just beyond the bifurcation, the vessel is also 3 millimeters in size. Proximal bit of the left main is 5.5.
The problem is that just above the diagonal, the second diagonal, the vessel size is more than 3, but the lumen size is about 2. Actually, so to avoid the dissection and implant a large stent is challenging. So next. So we are tried 3.5 38 millimeter Science Alpine stent, and my plan is to start just at the diagonal, because the vessel is getting large, proximal to diagonal, and start with a very low pressure to avoid the dissection. Next. So this was a 6 atmosphere. The nominal pressure is 10, but I started 6 atmosphere. Still the size is a little bit large than I thought. So next. So pull back and the 10 atmosphere. Next. So I end up with 20 atmosphere approximately. Next. Actually, we found that the stent was not covering the proximal end, not covering the full coverage of the plaque in left main. Next. Next. So our plan, as you can see, the position may be okay, but the expansion is not enough here. So our option was to use the NC balloon for post-dilatation, or use the post-dilatation stent with a stent, the larger stent versus balloon.
So this is an example of stent pot,
Yeah.
I think.
So I decided, I think if we dilate with the 4.0, 4.5 balloon proximally, there will be some dissection, at least the geographic miss. We dilated but not covered by the stent. So we decided to put another 4.0, 12 millimeter science stent. Next. So the positioning, next. Yeah, inflation with at 18 atmosphere. Next. So we tried to do the path. The position of a path is very important. So proximal margin of the distal marker is aligned with the carina. So just like that, so a little bit deeper than you thought. Next. The inflation with the 14. Yeah, next. Okay, this was the result. The polygon area is expanded with a very a little bit deep path. And now you like to he checked the OCT, and I'd like to show the image of OCT.
So we can bring the OCT images up. So we've got the stented segment here. So this is within the LAD. If you just concentrate on this panel here, so we've got, you can see the stents here. This is within that ISR segment, and we're coming back into the left main here. So the catheter is here, and then we're coming into the edge of the left main. Now, one of the features of this system is we've got an apposition indicator. So I'll show you where that is. This, if we turn it off, watch the, there's a white bar will come up. So this white bar shows that every stent segment, every stented strut within this segment is opposed. We've got it set at between 200 and 300 microns. We can set it at a slightly less, we set it at 200 if we like, but all of them are less than 200 because it's all white. So nothing's coming up as yellow, nothing's coming up as red. We then put the rendered stent view on, and so we can see the rendered stent view. You can see it within the 3D view. So this is the edge of the stent within the left main. I'll just rotate round, and you can see that the edge of the stent and all the stent struts, you can nicely see the interlinks of the Xience design here, the multi-link design. And so these are the struts. This is the proximal edge of the stent within the left main. So that's that 4 millimeter stent which was inflated to high pressure, and that is fully opposed. Here we are, so coming back into the catheter. So I'm coming out of the catheter, and I can see, here we are, the edge of the stent. I can look all around, and that is all now beautifully opposed.
Right.
And so that's a very nice example, I think, of we've had good sizing from the OCT. We've used that to dictate what post-dilatation balloon size we were going to use, or what balloon size stent size we're going to use, and we've got confirmation of apposition using these preset parameters. And I think it's a nice use of this software, and I think it really adds value to left main stem cases, in my view.
Okay. Can you show the distal end?
Okay, so I'll just, we've done some more recordings.
We are doing fine with the proximal left main, but
And so we haven't shown the distal. This is the distal vessel. Now we put in another stent at the end, and we're now left with the distal vessel looking like this. So if I just take you through these pictures, this is that distal vessel. The size of this, which you see on the, it doesn't look too diseased, but that is
it is before the third stent, after the stent.
do you want to see before the third stent?
Yeah, I like to see the
Okay.
dissection.
So I'll show you that view. So this is the end of the 38 millimeter stent. And in fact, what this has shown, and we see it angiographically, is that there is a almost occlusive dissection. So this is soft plaque at the end of the stent, and this is an almost occlusive dissection. And angiographically, so this, you can see this segment. Certainly this is something, if you're using the OCT criteria from the Illumian trials, this is something you would certainly treat. And that's in fact what we did.
I should have used a 3.0 stent instead of a 3.5 with the low pressure. So I tried, but I couldn't avoid the dissection distal stent edge.
Okay.
So I'm sorry for that. So while you put the angiography on the screen, please. Okay, next. 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 Down. Okay, you can see some stenosis just distal to the stent. So it looks like hematoma or some narrowing spasm, but OCT clearly show us that this was occlusive dissection. So we have no other choice but to implant another stent. Next. So this is 2.5, 15 millimeter science again. Next. And again, deployed with 8 atmosphere, low pressure to avoid the dissection, and pulled back with high pressure. And fortunately, diagonal survived even without the gelled wire. So this is currently we have now. But another issue is that distally, you can see a diffuse disease, and about 60 to 70%. So there was debate between Dr. Hill and I usually don't treat the distal lesion when we treat the CTO proximally.
But we agreed to disagree, but we agreed that we would consult the panel, and I just wonder if there's anyone on the panel who would treat this segment. We did get some extra information, and I'm going to show you that now, and that's from the OCT.
Meanwhile, what do you think? We need to treat the distal LAD, or if you like to treat the DB or DES again? The length is about 38, or more than that. I'm not sure we can cover this lesion with one stent.
So if I can we bring the OCT up? Can you see that projected?
OCT on the screen, please. OCT. Actually, I don't use OCT like this.
Okay.
You have an expert here, so I'm learning a lot about OCT.
So let me just show you how I would interpret this. This distal vessel, there's a very slight bit of atheroma, but it's relatively undiseased. So 2.67 in one plane, the EEL measurement, 2.441. So that would take a 2.5 stent so that would be sized to the EEL, so 2.5. Now, if we look at the lumen profile here, the MLA, and I'm going to show you, look at the axial view. So there's a bit more atheroma here. There's another tight lesion here, which is eccentric. That's the distal focal lesion you see projected in that PA cranial view. But look at this lesion. So this is really a very tight lesion, soft fibroatheroma, and then we're coming into the distal end of the stent. The stent itself looks pretty good. I'll put the apposition mapping on. So that stent is expanded in this segment. It's a little bit undersized here, according to the vessel size. And then we're going into this diseased segment with a very, very tight focal stenosis. Now that tight focal stenosis is, we could put a 20 millimeter stent in, or if we wanted to cover the distal stenosis, so that would be 20 millimeters from this point here down to here, or we could go beyond the distal lesion into this segment, and we would put in a 2.5 38, and we would 2.5 in this section, and we post-dilate it with a 275 or 3 in this section. That's certainly what I would do in my practice, or the alternative would be to use a drug-eluting balloon in this segment, so a 2 or 2.5 millimeter drug-eluting balloon. I'd be interested to hear what the panel thinks.
So, treat or not to treat, and the DB or DS. Yeah, Dr. Park prefer to leave it alone.
Okay, I hear that
What
view.
to say?
I disagree completely, but I think in this situation, if we put a pressure wire down here now, or we put an IFR catheter down, we would show that this is physiologically significant.
Yeah, physiological may be significant, but clinically, in the LED CTO, he's just a function class 2.
Okay.
So he'll be asymptomatic, and I will test the treatment test 1 month later, and we can do.
I suspect he will be left with a degree of significant anteroapical ischemia.
Do all agree with the leaving alone strategy?
Dr. Gwon, I think the panel is unanimous in leaving the distal,
Really?
the middle lady
You
alone.
lose.
I think they agree with Dr. Park. So thank you for your wonderful contribution and your educational case.
Okay.
And
Okay. Thank you very much. Yeah. Thank you.